Good morning, Dr. Rosensweet.
Good morning, Carolyn.
Are you hearing an echo? No.
No,
Oh,
I'm not.
yay. Let me turn this up. I am hoping that you are well.
I am.
Good. All right. Nice to hear. And we can get started because I have questions, as I always do, and they're good ones. So can we proceed?
Oh, yes, please.
Okay. So the first one, it comes in here and there, and it is, can compounded bioidentical hormones make autoimmune diseases worse?
Well, I'm not sure why someone would ask that question because the usual information about hormones and autoimmune disease suggest improvement of various ones. Like the first one I ever heard about is there's multiple sclerosis, for example. And it's not uncommon for a woman who's pregnant who has multiple sclerosis to go into remission.
Yep.
And there's a colleague of ours who wrote a book on the use of estriol in multiple sclerosis. Estriol is, of course, one of the three parent estrogens. And of course, you never say never in medicine. I mean, you never say, well, no, it's impossible. I can't imagine the mechanism in which a hormone would cause autoimmunity. The opposite, I could see hormonal balance is very supportive to health and healing. And yeah, so perhaps the questioner could come back in for next week and give us an example or reference to where there was concern. Now, you know, the only other possibility I can think of is that this questionnaire has an autoimmune illness, took some hormones, and it got worse. And, you know, every so often you hear a wild story like that. I'm not saying that's what happened. I'm just having to guess. And that's why you never say never in medicine. It could have set up a chain of events that aren't necessarily explainable, but led to worsening. When there ever is a question like that, we'll stop the hormones, see what happens. Does she improve? Does her symptoms related to the autoimmune phenomena improve? And then we may choose to restart the hormones to see, was it indeed the hormones that provoked the exacerbation of the autoimmune phenomena or not? And then is it the hormones or is it the various preparations the hormones are in provoking an immune system? Because common transdermal compounded bioidenticals are still being prepared in solvents. For example, when you get a jar of estrogen, whatever preparation you're using, over 99%, or a Topiclick or whatever syringe, however you're getting them, over 99% of what's in that jar of Topiclick is a solvent. That's a strong biochemical. Well, we don't do that in the menopause method. We dispense all of our hormones in certified organic oils. They're not solutions, they're suspensions, so you have to rotate the bottle before you apply it.
Right.
But I'm making wild guesses here, so if the questioner could come back to us and give us more specifics about her specific situation, I'd be able to answer that better rather than in the extremely vague way that I have done.
Well, one thing that you tweaked my mind on is just how powerful hormones are. You know, just in your statement. I mean, I don't know that all of us know how very, very powerful these hormones are to be able to.
They're as strong as biochemicals that are floating around in our body. The other thing I'd like to say is there are some diagnoses of autoimmune arthritis, for example, like rheumatoid arthritis. Some believe that that's got an autoimmune component. I'm one of them who believe that it can be the immune system attacking the joint, provoked by something. So in the world of autoimmunity, there's a couple things that really matter. One is women in menopause can often show up with very substantial joint pain, hip pain, shoulder pain, all kinds of pain. In fact, I think I mentioned on this broadcast before that I once had a patient, a woman in her mid-50s, who was on OxyContin when she first came to see me to consult around hormones. And I sort of shuddered and thought, am I going to be getting involved with an OxyContin addict? And it was because of bone pain and joint pain. And then 5 weeks later, she reported to me that she had dropped OxyContin cold after starting the hormones because all of her pain disappeared. And one could say that that could be mistaken for an autoimmune phenomena. In fact, women in the perimenopause or menopause who are having significant joint pain before doing really thorough workups or intense medical workups on the possible autoimmune disease, I say treat the menopause, see if that pain is still there. There are going to be instances where it is still there because it wasn't related to hormone deficiency at all. But there's going to be a lot of instances, and it's happened over and over and over again over 25 years of treating women in menopause, where that pain disappears. The other thing around autoimmunity, and you know this, so you're studying this right now, that word is a little deceptive. So I'm going to take a little diversion into autoimmunity.
Okay.
What we do know is there's an immune system response to something in our bodies. Like our own immune system could be attacking our own thyroid. That would be autoimmune thyroiditis, previously known as Hashimoto's thyroiditis, still probably known as Hashimoto's.
Yes.
Or it can attack the joints, and you can have autoimmune attack of your own joints, and it could be called rheumatoid arthritis. Or you can have autoimmune attack of other organs as well. But the word auto is a little deceptive. It implies we don't know why in the heck it's happening. It's just sort of automatically happening, right? It ain't automatically happening.
It isn't standardized.
Our immune system was provoked.
Right.
So the classic example that I was taught was 30, 40, 50 years ago in Tennessee. A patient went to their doctor, and the doctor diagnosed a condition and gave the patient a anti-parasitic called Flagyl, metronidazole. Very, very common. It's been around for a long time. And sometime later, the patient called up the doctor and said, well, I didn't know why you gave me Flagyl because I wasn't really clear on, yeah, I had some diarrhea. But here's the really amazing thing is my arthritis pain, which has been untouchable by anything medically to support me and to help me succeed at the arthritis pain. It's gone. Is Flagyl an anti-arthritic medicine? Is it an arthritis medicine? And here's what was proposed, because Flagyl is not known to be an anti-inflammatory or an anti-arthritic medicine at all.
Right.
Here's what is proposed. This patient had parasites, amoeba. An amoeba is a single cell organism. And the immune system doesn't like amoeba. It's not a personal thing. I wouldn't call it an insult. It's just like our immune system likes to identify what doesn't belong in us, and in that sense, it's not accepting it.
May I quote you?
Yeah, please. In your holistic functional medicine training, please tell your teachers that I said it's not a personal thing.
So funny.
We're not against amoeba. We just don't want them to be inhabiting our body. That's the only boundary we have around amoeba. And well, the immune system encounters the amoeba that have come into our bodies, and it goes, no, this is not us. We're going to eliminate this. And the way the immune system does that is identifies, let's say this is the amoeba. And the amoeba has got a cell surface. And on that cell surface, there's these proteins and lipids. And the immune system comes along and goes, huh? What are you doing here?
Right.
And the way it is, you don't belong here. So the immune system comes in and makes a template of the cell surface of that amoeba and walks away from the amoeba and goes to the rest of the immune system and says, we're being attacked by the mirror image of this thing right here. I just took a template of it. Let's go form a lot of antibodies and go after these critters that don't belong here. That's how the immune system operates.
Yeah.
So who's to say that the cell surface of amoeba, actually, it's just a single cell. It's not a lot different than our cells. The novice couldn't tell the difference between an amoeba cell and our cells. Who's to say that the same antibodies that got provoked by that amoeba could go and identify something similar in our body? There could be something similar. There could be a protein structure similar, a lipid structure similar to the cell surface of that amoeba. And indeed, this is what was proposed for this gentleman in Tennessee and this Tennessee doctor.
That's wild.
That the antibodies that were there to attack the amoeba that looked like us, didn't look a lot different, also had crossover and crossed over and identified something in this patient's body called their joints, their joint protein, and attacked the joint protein because there was a similarity there. And this is behind the theory of autoimmunity, that something provokes that immune system, and you're deep into the study of it. You were studying before we got on air today. I don't know what you were studying. I don't know if you were studying autoimmunity, but
amoebas.
So I don't, autoimmunity is a mystery until we figure out what in the heck is provoking the immune system. So a functional medicine detective will go try and find out what in the heck could be provoking the immune system. And there's usual culprits.
Yes.
And there's culprits. Where we go looking is critters in the gut could be provoking a cross immunity. Something when the gut eventually gets injured and gets, quote, leaky, because the holes in the gut that permit food to get through, not actual chunks, but molecules, they get bigger because they've been involved in inflammation. You get something called leaky gut, and you get larger molecules slipping into the bloodstream. And what larger molecules can slip in there? Well, partially digested food, because the human being is notorious for losing our digestive power. Kids can can digest food just so efficiently if they're healthy, but that doesn't necessarily carry on into adulthood. We can lose many of our superpowers, including the power to digest. We can partially digest food, and some of those larger than normal molecules can slip right into the bloodstream. And the immune system doesn't like that. What's this larger molecule than normal doing in the bloodstream?
Right.
Not acceptable, and the same antibody response can occur there. So what I'm trying to say is that anyone who has autoimmune phenomena should link up with someone who is trained to diagnose and treat. And what are they going to do? They're going to be looking for provocateurs to the immune system, and they're going to look in the gut, and they're going to look in toxicity. And so one of the morals of this story is autoimmunity. There's always causes to whatever phenomena that you can name. There's always causes. Yes, some are more serious than others.
Well, it's interesting because it segues me into a couple of my questions here. I'm going to present the 1/3 because I want to get to, if you don't mind.
Sure, please, go ahead.
This one, and then get to that one, because I think that one is definitely gonna take up a minute. So, yeah, I'm gonna. Okay, so my second question is, I read that women choose to take their oral progesterone rectally as much is lost via first pass through the liver. Meaning, I know that you say that oral and oral DHEA are okay. But how can this be if they still have to pass through the liver? You say no to the oral estrogens and you say no to the oral testosterones, but not so with progesterone and DHEA. And so the confusion is, how come progesterone and DHEA, okay, you get it, right? don't do this first pass through the liver thing. And why are they okay? And is it okay to take them rectally or better or what? Help.
I just love the image of taking something rectally.
Oh, me too, by far.
Give me the chance, please. Is there anything I could be assimilating that I could take rectally? Just kidding.
Right, or giving. I mean, depending.
Sometimes it is appropriate. And so I don't want to discount it. And sometimes rectal administration is excellent and needed. So I'm not here to criticize it, but just as a personal preference, if I can take it via some other route, rectally, okay, get your socket to me. Well, there is a great technical specificity here, and it has to do with oral administration of hormones. This pertains to a lot of other stuff, but we're talking about hormones here. Let's take them one at a time. Yes, you can administer estrogen orally. Mm-hmm. In fact, it's been done for over 1,000 years. Mm-hmm. As I mentioned before, the Chinese used to, the Chinese aristocracy used to set up these exquisite outhouses for young women to collect their pee. And they also did the same thing for young men, collect the pee of young men and dry it out. And there's a powder left behind. And the aristocracy used to take that powder. And why? Because they felt better and they retained some youthful qualities. Why? Because there were hormones in the pee. So fast forward to the 40s, 1940s, and pharmaceutical manufacturers wanting to come up with a really a way to manufacture hormones for women in menopause, believing that they were beneficial for women in menopause, collected the urine of pregnant mares, large animal, lots of urine, lots of hormones. Oh, it was very pleasant. They put the pregnant mares in stalls and catheterized them. No, animal rights folks didn't. Yeah, we get it. And there's in horses, horse urine has 50% of the estrogens present in horses are not present in the human female. So, right. However, there's a lot of women on this planet who have benefited from Premarin, pregnant mare urine derived estrogens. Absolutely. So I would never want to criticize that. And they did really well. And that was understandably a way to mass produce it. In fact, there were 18 million women in 2002 on Premarin and Prempro. In the United States, 40% of the women in menopause. And my God, they benefited by it. Now, things have come a long way. Now we can get molecular identical to human. And we can prepare them, and pharmaceutical manufacturers can prepare them from plants. So you can be sure, along with me not being a great fan of rectal administration if I don't have to. I'm not a great fan of horse urine if I can get bioidentical that's coming from plants prepared by compounding pharmacies.
Yeah.
So, yeah.
Yeah.
Now, let's talk about oral estrogens. Thank you, Carol. Carolyn, I knew you were about to corral me and get me back into the question.
It's fine, really.
Good. I'm so grateful we're doing this together. Because I can read you telepathically. Dr. R, please. There was a question I asked you if you don't remember.
Yes, you do remember.
Estrogens can be taken by mouth, and they still are administered by mouth. However, estrogens are steroid hormone. They're fat soluble, and when you swallow something that's fat soluble, it goes through a different pathway. And yes, it goes from the gut directly to the liver. And somewhere between 75 and 95%, wild guess, of what you administer estrogen through the mouth, it gets metabolized in the liver before it even gets distributed to the body. Or the
So
flip side of that is you have to administer much significantly larger doses if you're going to give it by mouth, because you're going to lose 70, 80% of it right away by direct metabolization, conversion of the estrogen that you administer orally. You're going to lose it right away, and it's going to become metabolites that are not effective as estrogens, and about 20% will escape and make it to the whole body. So you have to administer larger doses, and this has been studied, and there's a wonderful study you can refer to about this. In fact, one of our pioneers, Dr. Jonathan Wright, has pointed out in a study that he feels that a lot of the risk that has been ascribed to estrogen really is because you have to administer these much higher doses.
okay.
And then he recommends, if you're going to do oral estrogens, which he does not recommend, you should use much lower doses so you don't get these wild metabolites coming up.
Okay.
Yeah, I'm going adrift. All these questions you ask, there's a lot of moving parts to them. Now, here's the main thing about oral estrogens. Why we say no, don't do it. You don't need to take estrogens orally, and don't do it. And they're still putting out these estrogen products, but we say don't do it. And it's not because I have an opinion. I'm relying on scientific research, which everybody who pays attention to these hormones knows. And that is, oral estrogens can provoke two things. One of them is the coagulation mechanism.
Right.
And the other one is inflammation.
Right. We discussed
Neither of which are desirable in any sense. The coagulation mechanism is a very delicately balanced thing. We've got to be able to coagulate in case we get struck with a javelin or something like that, or a spear.
Javelin.
So we've got to be able to clot. But we don't want to clot too easily, because then we'd be clotting while our blood's circulating in our body.
No, not good.
So we want to be spot on. And this clotting mechanism is so technically complex, it's mind-boggling for those who study the details of it. There's so many moving biochemical parts. It's so exquisite. It's outrageous. It's very delicately balanced. And what we know about the American population, oh my God, we are leaning in the direction of hypercoagulable in general. Holy mackerel. And a lot of it relates to these chronic viral infections that are occult and inflammation. But regardless, the general population is hypercoagulable just in general. And we don't want to do anything that would push it further. Or even someone who's spot on. We don't want to lean them in the direction of being too easy to clot. No way.
Well,
now, where did we first find this out? Young women in birth control pills. They contain estrogen and a progestin. And there's a certain percentage of women who took the birth control pills that got clots in their veins. Thrombophlebitis. They got inflamed. Sometimes those clots broke loose and went to the lungs. Pulmonary embolus. Rare, but it happened, and it's a known complication of the birth control pill. And I learned that really early on. And not only that, anyone who's working with women in menopause and he's taking a medical history, I was taking medical histories of women who said to me, oh yes, when I was 25, I took the birth control pill and I had a clot in my leg, so I had to stop. Or someone else said, oh yes, I took the birth control pill and I had to stop it because I had a clot travel to my lung. That's threatening. A clot to the lung.
Yeah.
A leg was inconvenient. A clot to the lung, it can be bye-bye from that one. So we do not recommend in any case at all oral estrogens because they can promote hypercoagulability and they can also promote inflammation. We don't need extra inflammation. No oral estrogens. And you know what? They're still producing them. There's a brand new product heavily touted by pharmaceutical manufacturers that's a combination of estrogen and progesterone, and you take it orally. When will we ever learn? And not only that, when you apply estrogens to the skin topically, they absorb beautifully. We can see it when we test. A woman's low in estrogens, we have her apply estrogens to her skin, her estrogens increase, no matter how you test her.
Yeah, right.
Duh, because the skin is extremely absorptive. So, and theoretically, there is no increased coagulation. The medical literature says topical estrogens do not increase coagulation. So that's why we do not recommend estrogens. Let's take the testosterones. We do not recommend oral testosterone because for some reason it can injure a liver. End of story. We don't want to injure the liver. No one's got the room. There is no product that is oral testosterone anymore. And there's no need to administer testosterone orally because, oh, here's my testosterone.
Right.
I use topical testosterone every day.
I do too.
I'm an older gentleman. Well, at least I'm older. You can make your own evaluations about the gentleman part.
You're a gentleman.
You've seen other parts of me. And it absorbs beautifully, as we can measure by testing.
Well,
so there's no reason to give topical testosterone. Now let's go to the question. Oral progesterone works fine. Yes, it does do the same thing that estrogens and testosterone does given orally. It goes to the liver first pass through the liver. However, it doesn't do anything obnoxious. Oral progesterone doesn't have any of these downsides. It does not promote coagulation. It does not have adverse effects. It does not injure the liver.
Same with DHEA.
And same with DHEA. Both of them can be administered orally. In fact, with progesterone, we sometimes take advantage of one of the things that happens when it's administered orally. Like I say, 70, 80% of it, 90% of it is metabolized right away in the liver. And the progesterone itself never makes it to the rest of the body except for 10, 20% of it. But one of the metabolites of oral progesterone can help a woman sleep. So there's times when a woman has sleep disturbance. Oh, how common is that in menopause? It's almost universal. We will purposely administer progesterone orally. Now, we always start out with topical progesterone and we always start out with topical DHEA, but we're fine to switch. Now, in medicine, you never say never. And I had two patients, and one of their names was Nancy and the other one was Denise. And I haven't seen them for about 20 years, but I remember them very clearly. Because when I gave them topical estrogens and progesterone, they said to me, both of them said at different times, gosh, my leg is aching like when I had thrombophlebitis when I took the birth control pill. So we stopped the hormones and the leg pain went away. And we started them again and the leg pain came back, discomfort. We never let it go very far.
Right.
Now we eventually narrowed that down and they eventually were able to take hormones, but you never say there's absolutes in medicine. Because the absolute I said was oral estrogens affect coagulation. Yes, they do. And transdermals do not. And in 99% of the time, they do not. No problem. Doesn't matter if a woman had thrombophlebitis when she was young. You can give her topical estrogens and progesterone. She'll do just fine. But you keep your eyes open, like I did with Denise and Nancy. So you never say never. But in general, we feel very safe administering estrogen and testosterone topically, and progesterone orally, and DHEA orally.
And then again, your favorite way, not which would be rectally.
Oh yes, thank you.
Yeah, no, it's fine. I mean, the more than
Why?
one woman, wrote about this, and the rectal thing seems to be.
I don't know about rectal, because rectal progesterone has been given.
Mm-hmm.
And it's been given to pregnant women, and I have no technical issues about that, but I'm not knowledgeable enough about it, because we never have to turn to rectal in menopause. We just never had to do it, because topical works, and if topical isn't the optimal for progesterone, we give it orally, and we take advantage of that first pass effect.
Right.
So I can't say for certain, because is rectal going to go anywhere? Is any of it going to go to the liver? There's lymphatics down there, and I'm not certain, so I can't answer that with expertise. But listen, if you like rectal progesterone, who am I to complain? I wouldn't be using the commercially available rectally. I wouldn't recommend the commercially available progesterone. For one thing, it only comes in 2 doses, 100 milligrams and 200 milligrams, and that's going to be excessive for a lot of women, as we've shown. Another thing it's got peanut oil in it, it's got these titanium in it, it's got these other chemicals in it. So who needs that? I would get compounded bioidentical progesterone if you want to administer it rectally. And there we go.
Yeah, that's a good point. Well, thank you very, very much. It's a great answer, and I think that that's going to be very helpful, because it's confusing. It can be very confusing. This is going to be, I think, a yes or no answer.
Good luck.
Yeah, good luck, right?
Good luck, Carolyn Shapiro.
I know that we have time, and I think that these other 2 questions will be kind of easy, and then take us out with one that's pretty heady. A woman writes in, she's 78 years old. She says, I've been taking hormones for 20 years now. I've done my time. Is it okay for me to stop?
Unlikely okay. One thing we have seen, why would she want to stop? That would be my first reason. Is it inconvenient? One thing we have that has been recorded is that a woman who stops her estrogen, and estrogen is so protective to the bones, can develop osteopenia and osteoporosis really rapidly, no matter when she stops. Then I would ask, why would you want to stop? Because the benefits of these hormones, let's say estrogen, for example, to the brain, to the arteries, to the skin, to the bones, to the mood, to the well-being, to the sleep. I could think of about 20 reasons to not stop, and I can't think of any reason to stop. And I can think of reasons that if you stop, look out. Some of you are going to then get rapid development of osteopenia, bone loss, and osteoporosis. Some of you are going to get cognitive decline. Some of you are going to get vaginal atrophy. There's no way that vagina is going to hold up to no estrogen. It does not. It atrophies. And when it atrophies, the tube that empties the bladder, the urethra, empties into the vagina, and you can get irritation of that urethral opening there, called the urethral meatus, and you can get recurrent bladder infections from that irritation, and you can get urinary urgency and incontinence from that, and the vaginal atrophy is almost a guarantee. It's not like that the vagina needs estrogen for its health, and it also needs DHEA and testosterone.
Yes.
So I can think of many reasons to don't ever stop for every day you've been on Earth. Who invented that stop thing? It was there was no scientific basis to it whatsoever. The Women's Health Initiative falsely reported that there was increased risk for breast cancer, heart attack, or stroke. I can say that again. Falsely reported. Even in the Women's Health Initiative itself in 2002, it said that Premarin, the use of Premarin, horse urine-derived estrogen, had less risk for breast cancer, heart attack, and stroke than women who did not receive Premarin. Oh, that sort of went unnoticed. And women who received Prempro, the combination of Premarin plus this progestin, no, I'm no fan of progestins, they had a 1.26 relative risk ratio. Well, in the original Women's Health Initiative, that was reported as statistically insignificant. In science, that means there was no increased risk.
Right.
But the press got a hold of it, and God knows how this happened. Well, there was a member of the original study committee that was anti-hormones. Not for any basis, but he had this opinion that women shouldn't be taking hormones. And he had enough sway to get that Women's Health Initiative published before he had the permission of the committee to do it. The politics are just disgusting. It's discussed disgusting different than disgust. It's discussed in this book called Estrogen Matter, a childhood friend of Carolyn Shapiro's, Avram Blooming, a friend of Carolyn Shapiro's dad, an oncologist, wrote this book, and that's the expertise on this matter. And so it's really crazy. Well, the original study committee retracted it.
But how many years later?
They said after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke, Premarin or Prempro. They knew it by 2006. There was no increase in incidence. So, oh my God, this topic makes my hair stand on end to this very day.
Right. And we have a woman who's just come up, Liza, and Facebook user, good morning, both of you. And she says, does HRT increase the risk for estrogen receptive cancer? And this is what we're discussing right now. So.
Well, that's a great question.
Yes, of course.
And here's the facts. Here's the science. Women who are taking HRT, this is Premarin, Prempro, bioidenticals, are at less risk for developing breast cancer, heart attack, and stroke than women who go untreated. That's the science. Now, we're all at risk for 1,000 diagnoses. As a man, we're all at risk for cancer. As a man, I have special risk for prostate cancer, and there are reasons for this. Women are at special risk for breast cancer, and there are reasons why they are. But even knowing that, women who are treated with hormones, even Premarin or Prempro, are at less risk for developing breast cancer, heart attack, or stroke than women who are not treated with hormones. That's the science. In fact, women who have had breast cancer and have had that breast cancer treated are at an increased risk of recurrence of that cancer as compared to a woman who's never had breast cancer is at risk for getting breast cancer.
In the event they.
Yes, and the women who've had the breast cancer and have had it properly treated are at less risk for recurrence if they're treated with hormones than if they are not. And we're talking Premarin and Prempro. Right. And anyone who really wants to read the science should read Dr. Blooming's book called Estrogen Matters. He spells it out. So that's the general thing. But the question was, does HRT increase the risk for estrogen receptive cancer? I was including all breast cancers. Mm-hmm. Women who've had breast cancer are less risk for recurrence if they're treated with hormones than if they are not. Just to take it a little bit further, Both Dr. Blooming's wife and daughter had breast cancer, and they are being treated with Prema and Prempro. Now, how about the estrogen receptor? Well, I've spoken to Dr. Blooming about this, and it's a little bit of a gray area. But here was the opinion. And Dr. Blooming, I'm believing I'm quoting you as you and I have spoken about this, that it rattles someone's nerves to think a woman had estrogen receptor site positive breast cancer to take estrogen. But Dr. Blooming has put it this way: these cancers are amalgams. They got a lot of different things going on in there. And when you see an estrogen positive, a cell that has an estrogen positive receptor site in it, has an active estrogen receptor site, that's what that means. Estrogen positive means the cell is still behaving like a young person's breast glandular cell is. It's got estrogen receptor sites in there, and they're active. They can exist within a cancer, but that's not what's giving the problem. The problem in a breast cancer is not the cells that look sort of normal and are well differentiated. They can exist within a cancer. It's the cells that have broken loose the cells that are broken loose, and they are no longer in control, and they have mutated, and it's these cells that are undifferentiated, that don't have estrogen receptor sites in it. They're undifferentiated. They're cancer cells. They're the ones that are the problem. So we're in a gray area here. And a lot of doctors are going to be nervous. But the science says this: if a woman has had breast cancer, that includes estrogen positive receptor sites or not, and she's had the breast cancer properly treated, she's at less risk for recurrence of that breast cancer if she's treated with hormones than if she's not.
Thank you so much for saying that.
And should we take precautions and be careful about our health? And we're all vulnerable for cancer, along with a million other diagnoses. Yeah.
Yeah. Yeah. Thank you.
We always go by a case-by-case basis.
Mm-hmm.
And, you can be very scrupulous about careful monitoring of a woman who's had breast cancer. Like just to let you know how it comes down from me. 20 years ago, I got approached by women who had breast cancer and had the breast cancer treated, and they were really disabled by no hormones. Their life was so disruptive that they were desperate. And they asked me, please, would I treat them with hormones? And was I nervous? Yes, I was. Because my medical license becomes vulnerable, because the common belief out there is that you should never give hormones. Not that it was based on any science. No way. It was not based on science. This is even before the Women's Health Initiative. But there was a fear that hormones cause cancer. No. Do hormones cause cancer? No. They do not cause cancer. It would be rampant in young people by the age of 20 who have these super high levels of hormones, male and female.
Right.
And there's a lot of reasons. These are natural biochemicals. They support our health. However, it came down to me, like, was I going to treat them with hormones or not? Was I going to put myself at risk? And I can tell you that over the years, I have treated several women, and I still am. Women who've had breast cancer and had the breast cancer properly treated. I still am treating them with hormones. And I had to make that decision personally. So just to let you know where I stuck my neck out. And why did I stick my neck out? Because number one, I sided on that the hormones didn't cause cancer and that the women needed the hormones for their health. I decided the medicine, this is before we knew what Dr. Blooming knows and has written about. So as I examined each individual patient, I came down on the side of examine each individual patient and see if they're still vulnerable for cancer, and see if they're the reasons why they got the cancer are still there, and see if they're doing everything they possibly can to take care of their health and turn the tide. And the women who happened to approach me, that's what they were doing. They had gotten super vigilant. They understood the multidimensional reasons. They were addressing those reasons. They were highly committed to their health. And yeah, all these years later, I know these women's names, and I'm still treating a couple of them. And they're long past the 5-year mark, long past it. Yeah.
I'm thinking of one in particular. Long.
Oh, yes. Oh, yes, there is one in particular.
Yes.
So it comes down to this. Good medicine also allows us to be extremely vigilant in monitoring a woman that we're concerned, does she have breast cancer?
Yes.
Because if you have breast cancer and you catch it when it's early, cure is almost 100. It's close to 100%. So there's wonderful techniques called breast health, and it's in our book, Happy Healthy Hormones, that Carolyn has posted, free PDF. You can download it for no charge, from Ins and Outs of Menopause. There are issues to promote breast health, so we certainly are advocates of that. There's issues to self-examine, which happen to be part of the lymphatic drainage. I mean, you think of self-examination of breast. Well, how do I think of it? I think of it as this is lymphatic drainage. This is manual lymphatic drainage of the breast, right, which is a healthy practice.
Yes.
And, reduce bra wearing, no compression bras, no underwire bras. There's lots of things for breast health. And then if you're doing occasional self-examination, and you're in the shower and you put soap on your breast and you take your hands and you start at your nipple and you move outwards with both hands and you're carefully feeling your own lumps, you're going to detect something. Mm-hmm. It really takes you understanding your own lumps. Normal breast tissue is lumpy. This is the glands. That's what you're feeling. And so if you are going around all quadrants very carefully, you're going to feel your own breast. You're going to detect something. Where'd that come from? If that should ever happen to you, and if you detect a breast cancer, and I'm a super strong advocate of mammograms, and I'm an advocate of thermograms, but not as a cancer detecting technique. No way. Mm-hmm. But we can pick up inflammation in the breast by thermography. So between self-exam and mammography and these exquisite other techniques, imaging techniques like even ultrasound or MRIs of breasts, and things have gotten very sophisticated, we can monitor a woman that we're treating. So big complex topic. Read Estrogen Matters. If you've had breast cancer and you're concerned about it, read Estrogen Matters by Avram Blooming and Carol Tavris. Fantastic.
Excellent book. Excellent book. And piggybacking on that, so is Happy Healthy Hormones too. Absolutely complimentary. Both books, fabulous. Great to learn from. Thank you. Welcoming in Charlotte, another Facebook user who's saying, me desperate. Oh. Thank you for answering. Good morning and good morning. Okay, so here's my last question, and we could do an entire interview on this too, as we usually can. But due to our last interview, this came up big time. So we discussed the gut. So last interview, we discussed the gut. If we are healthy, will we get through menopause easier? You've always been a holistic doctor. I don't even want to ask you why. She asked why. But how is it that we can help ourselves through to make menopause easier for ourselves? There has to be something about the gut that we need to know about that will be helpful to us. Big question.
To start off with, holistic doc, what does that mean? I mean, to me, there was no such thing called a holistic doc.
Right.
There were naturopathic doctors. There were chiropractors that got interested in nutrition back
Yes.
when I was in medical school.
Yes.
And I was one of those folks, I was one of those doctors that loved medical school and treasure my medical doctor training. Oh my God, I use it every day. And it was, to me, it was like going to a synagogue or to church, going to medical school. And at the end of medical school, I started developing these other interests. I started asking myself the question, how do people stay well and how do they get ill? And so I ventured into other subjects. I was curious about nutrition. I had this wild idea that what we ate could make a difference.
Yes.
And I got interested in exercise, and I got interested in, toxicity. All these chemicals that have magically or disgustingly appeared in our environment. I started to think that these are problematic. And then I became very interested for personal reasons and for just curiosity about health, emotions, and an exaggerated response to stress. And that's huge because that's what's throwing us off. I've just named it. I've just named the causes as best as I can identify. There's 5 causes to all illness and all health. 5. It relates to adverse nutrition, adverse exposure to environmental toxins, getting poisoned, too much or too little exercise, and an exaggerated and biological triggering of the fight or flight response to the stress of life. The stress is natural. The stress is beneficial. The stress is important to us. But if we overreact and we recruit the biology of the stress response over and over again, that's one of the major causes of knocking our health out. And then there's a 5th cause, and it's mysterious. There's some people get ill, we just can't explain it.
Yes.
And that's not the crucial thing. The explaining why is not the crucial thing. The helping them get better is really crucial.
Right. Absolutely.
So that's what I got interested in. There was no holistic. And what did I learn? Hey, the naturopaths had a lot of really interesting knowledge about promoting health and detoxification and health. And there's a whole naturopathic body of knowledge that is very special. And gosh, there were so many natural health advocates at the turn of the 19th century. There was people getting way into health stuff, and some chiropractors took really special interest. All kinds of health professionals did. And so they just interested me. And so and then I wasn't the only one. My God, there was thousands of folks who cared about health and thousands of professionals who cared about health. They just started asking more and more questions. And also there was some science involved. And so when you get down to the gut, for example, there were some gut people, they got specially fascinated by the gut. Why'd they get fascinated by the gut? Because they thought there was problems that could develop if you were messing with your gut. And one of the things they identified was the American diet. If it was too heavily loaded with simple carbohydrates, sweets, it could really change our population that lived within us. We got these 3.5 pounds of friendly bacteria that we need and love, and they're us. In fact, when I call you Carolyn, I'm not just referring to Carolyn Shapiro.
Right.
I'm including your 3.5 pounds of bacteria that's also named Carolyn Shapiro.
So is it who's the host, who's the human, who's
who in there?
Who's running what?
Exactly. So I'm just giving you examples of this whole thing called holistic doc. Now I want to go return to the question. Good health makes a difference at any time of life, whether you're a child, adolescent, young person, older person, all these health measures, they all matter all the time, big time. As far as addressing menopause, though, yes, good health is going to make everything easier. However, there are some of these things that happen when you lose your hormones that are so intense. For 75% of women, they're life disruptive. And just go around interviewing men. Ask them how they like their erectile dysfunction.
You're right. Yeah, love it.
Ask them how they like the loss of their drive and their male energy and their thinking ability. And yeah, they'll talk to you about it if they're honest. So it's not different for men and women. And so I'm going to say, don't forget the hormones. Yes, take care of yourself. Do as many health measures as you can possibly integrate into your life and be a devotee your whole life, including looking after your gut. But don't think you're going to get around it, the hormones. They're the strongest biochemicals in our body. And you know, it's really interesting. We're not the same human beings that started off living on this planet when we were cruising around the tundra with our clubs and stuff.
Right.
And digging up roots if we were in the Amazon and stuff.
Right. Can you move along here? Right.
We're not the same ones. Those folks there wasn't such a thing called menopause. They just didn't live that long. That was very rare. You didn't see women in menopause, and men were dying earlier than the women were. So what are we going to do with these things that have occurred throughout human history that lets us live longer and beyond reproductive years? And I'd like to call attention to, there's this gynecologist that has written this article in the New York Times that Andre pointed out to me that is just so amazing. It's this is a sidelight, but it's called The Opinion. Women can have better menopause. And so I'm just going to point this out because I just highly recommend it. And it's by a gynecologist, and her name is Dr. Jen Gunter, Jen, last name Gunter. And it's an article in the New York Times, but she's written books, the Menopause Manifesto and the Vagina Bible. And I just got so impressed. I just started reading this article, and what a sidetrack that is, right? That I should start mentioning that. But there's this whole new world, and it's people are living beyond 40 and 45. And so I want to go back to the questioner who said, is there the spirit of the question to me was, can we do this without the hormones? And my answer is no.
Right.
Most women are not going to do well. You may live, but you're going to lose your muscles. That's almost guaranteed. And that leads to cane, walker, and wheelchair and loss of bladder control. You're going to lose your vagina. That's not a curse. It's just what happens when you don't have and whether you're going to be able to think clearly and have healthy arteries. It's very profound, these hormones. And men, what are you going to do if you lose your hormones? You're going to lose your erection. You're going to lose your heart strength. You're going to lose your drive. You're going to lose your mood. You're going to lose your muscles.
It's kind of
Walk down the beach. I lived in Florida for quite a while, and you don't see a lot of older people walking the beach. Ooh, that's not so hot. But when you do, take a look at their lower extremities. I'm talking women. They don't have thin, strong thighs for the most part, especially if they're normal weight. Well, neither do the men. They get sarcopenia too. They get loss of muscles. So what I'm wanting to say here is, yes, take care of your health. Take care of your gut. But don't leave out the hormones if you want to live long and prosper. Do the hormones. Occasionally there'll be you'll hear some story of, and they were 110, they smoked the last 60 years of their life. Those stories exist, but they're not common. That's not the common things the doctors see in older people. Go to nursing homes. Nursing homes are this huge business in the United States in assisted living facilities. Why? Because people lose their ability to take care of themselves. And one of the main reasons they do, and Dr. Lindsay Berkson and I, who, by the way, just for fun, is on the cover of the Rotogravure, well, at least the Rotogravure of holistic medicine, Dr. Lindsay Berkson.
Can you Google that? Can one Google that?
Yeah, the Townsend letter. This is the doctor for holistic physicians and those who are, at any rate.
Thank you for that.
Yeah.
She's great.
So the main thing is don't leave out the hormones.
Right. And
you do so at your own risk. They're too important for everything that matters to you. You're going to want to be crawling down on the ground with your great-grandchildren when you're 90. As I've said many times on this show, people's lives mean as much to them when they're 90 as they do when you're 40 and when you're 20. Sometimes more.
Yeah.
So you're going to be able to want to walk and talk and laugh and think and stand and play with your grandchildren and have a good mood and have arteries that are functioning and bladders and vaginas that are functioning. And you may even want to have intercourse, which you can do, but you're going to need the hormones for all of it. And what I wanted to say about Dr. Berkson, she and I were having this discussion about what would happen to American healthcare costs. Would it save Medicare if all the women and men were on hormones? So many of them would not have to be in assisted living facilities and nursing homes. It's the great gift to American healthcare that we need to preserve it and thus shift all those funds.
Yes.
I mean, God bless those who work in nursing homes and what contributors they are. They're just extraordinary people in so many instances. And I have personal experience with them, and I honor and respect them, but they could find other work in the healthcare world. There's no loss of healthcare needs.
No.
Anyway, sorry to drift, but don't leave out the hormones. That's what I'd really like to say.
So it's 8:03. We've gone over. Let me quickly ask this, because I know you can say yes or no to this. We addressed it at the very, very beginning of the interview. Liza asked, so then a woman can start taking hormones in her 70s and use
absolutely.
100.
As I've mentioned before, there is a caveat. Best case, a woman starting taking hormones in her 70s is going to find an expert. That's your job. That's every woman's job. Go shopping. And you don't stop shopping until you encounter someone who's specializing in treating women in menopause with bioidentical hormones and is expert in it. You find that person that you trust and that is that knowledgeable. And those who are really educated are going to just pause. And during the medical history, they're going to start questioning the 70-year-old who hasn't had hormones. Do we need to do a special evaluation of the coronary arteries? And the answer to Liza, yes. I started treating my mother-in-law when she was 86, and my mother when she was in her late 80s. Was that the ideal time? No, I'd much rather start treating a woman in perimenopause. But anytime. And sometimes we have to pause and see if do we need to do a special evaluation of the arteries to the heart, because when they've gone years and years without estrogen, sometimes they have arteriosclerosis and sometimes there's a clot there to consider. That's highly technical, but who's gonna be able to tell you the right thing to do? Someone who cares about specializing and being great in menopause.
Yes, absolutely. Yes. Wow, do I agree with that? Yes. Do we have time?
No, I'm very sorry. It's I'm on to my next.
Bewitching hour. Today really is Thursday. I looked it up 100 times. Hi,
I was right there with you. Yeah. See you next week.
Yeah, right. Awesome. I don't know. It's all good. Thank you for humor. Thank you for humor. And thank you for you, Dr. Rosensweet. And thank you for all the women that have come up. I want to wish everybody a really great, happy, healthy, fun-filled weekend. Laugh a lot. And I will have questions for you on Tuesday.
Thank you, Carolyn Shapiro. Look what you sourced here. Look at the amount of support that you are to women in menopause. We're very grateful for you.
Thank you. So, I hope.
Yes, we are. Yes, we are.
I do. I'm one of those passionate people.
Yes, you are. Alrighty, so we'll see you next Tuesday. Providing today is Thursday. Can we confirm that?
Today is Thursday, and they told me all day, too.
Okay.
Okay?
So we'll see everybody on Tuesday.
All right. See you later, everybody.
See you later.